咪。好，唔該，我哋。
Thank you. We have a quorum, so let's start this meeting. Let's invite the administration in first. And first of all, let me report to members that last time the Privacy Commissioner agreed that on items being discussed by the Bills Committee, he will be submitting some revised provisions, and his work has yet to be done. He hasn't given us any date yet, but the Secretariat will follow up on this matter with him. And as discussed just now, before we move on to the clause-by-clause scrutiny, we'd like to have this information from the Privacy Commissioner first, so that we can consider in one go. That is, whether the Bills Committee will recommend those to the administration or not. So we'll do that before we move on to the clause-by-clause scrutiny. But I guess probably it won't be at this meeting, or it will be at the next meeting. So thank you for attending, representatives from the administration. I won't go through the list one by one. This time, we'll be discussing 4 papers, responses from the administration. These papers are basically in response to the details raised in our previous discussion. The first paper, well, perhaps Mr. Chan can walk us through the papers one by one, because some papers were submitted to us in June or July. And at those meetings, we invited the Privacy Commissioner to go through the 6 points raised. And perhaps Mr. Chan can walk us through the papers to refresh the memory of our members. The first one is a response paper tabled by the administration at the meeting on the 16th of June 2014 on some follow-up issues arising from the discussion then. We have a PowerPoint, and Mr. Chan, would you please walk us through this paper thing? Yes, thank you, Chairman. Let me first walk members through the response arising from the issues from the meeting on the 16th of June 2014. A number of points are covered in the paper. Some members asked, under our arrangement in relation to substitute decision makers, SDMs, what our arrangement would be. And these SDMs may be parents, family members, or healthcare providers. And we have a priority list for the SDMs, and at that meeting there were questions on the SDM arrangement, comparing to the existing practice when a doctor treats a patient in an emergency situation, why the healthcare professional is listed of such a low priority. Now, the point is, when the patient is unable to make a decision, then the parent or the guardian will make the decision in substitute of the patient, followed by the healthcare service provider. Now, last time the member asked about normal medical treatment performed by the doctor, and that priority will be given to the doctor first. And in fact, these two are not contradictory, because last time the question was about medical treatment. So medical treatment is supposed that it's on the list. Well, even without this arrangement, at present, for the purpose of making medical treatment, the healthcare professional can check the health record of the patient, and with the EHR system, sharing system, even if the patient hasn't joined the system under emergency situations, the medical professional can still look at the health record. So there is no conflict. That is in relation to point A. A member also asked about the meaning of the STMs being required to accompany the patient. By accompany, we mean that in fact over the phone, the STM cannot just state that the person is the patient's family member, and that the STM must show up in person. And another point is about public-private interface, and that public doctors can check the health record in a private system and vice versa. But previously, we have launched a one-way system, and that is a pilot project on electronic patient record sharing, PPR, EPR, and that the system is still ongoing. It's still on a pilot basis. And over 360,000 patients have joined the scheme. And we conducted a survey. Last time, a member asked whether a survey was conducted, whether the public was satisfactory with the or satisfied with the system, on whether there were any suggestions to improve the system. And we have provided the executive summary of the 2 surveys of the pilot system. Finally, in a moment, I will make a PowerPoint presentation, and that is code of practice may be issued by the Commissioner in future, and some members asked the purpose of this code of practice and why the power was given to the Commissioner. And I will now defer. I'll defer to my colleagues to walk you through the code of practice and whether there is any duplication. So, if Chairman you agree, I'll invite Dr. Wong to walk you through the code of practice. So let's hear from Dr. Wong first before we start the discussion. Thank you. I will walk you through the details of the code of practice in the system. In the future, the Commissioner for the Electronic Health Record will be empowered to issue code of practice which sets out standards and guidelines that will it will be based on the views offered by the stakeholders, medical professionals, IT professionals, and a working group.
And this is different from the professional code to be observed by medical personnel.
As we only provide the best practices in the COP, other equally practical or feasible ways will also be acceptable. The purpose of the COP is to provide guidelines and suggestions on technical and operational aspects, in particular to provide the best practices for the purpose of ensuring security and privacy, and it's mainly for healthcare service providers and staff members. And in other jurisdictions like UK, Australia, there are similar guidelines for medical practitioners and participants of the system. There are also similar guidelines and our technical guidelines, security arrangements issued by the relevant authorities. Therefore, we have also taken on board medical and technical considerations. We've drawn reference from local and overseas practices, views of stakeholders, and the code of practice will be announced to all the healthcare service providers and staff members joining the system. And we will set up the framework, that is, we'll register for the healthcare service providers and also healthcare recipients, and a consent and participation and the responsibility for managing healthcare providers or healthcare practitioners and also to share the electronic health record, or to share the information onto the EHR SS. We'll also remind medical practitioners of matters to note when using the system, and on system security and information privacy, there will also be reminders. And then also based on the PDPO, the participants will be reminded on how to work with the PDPO and the patients on the data access requests and data correction requests. Now, first of all, it will set out the criteria and the procedure for registering healthcare service providers and health and staff members, and there will also be inspections on the status of registration of professionals. Number 2, it will also set out the procedures and matters to note when registering for healthcare recipients, how their information will be updated, and the arrangement for SDMs. For each participant of the EHR sharing system, the EHR should be ensured that they understand the system, and they must give their consent, in particular with the use of Hong Kong ID.
The code will also detail the management responsibilities of the medical personnel. For example, there will be training and supervision to make sure that these healthcare personnel make the correct use of the sharing system. And then the medical records are kept by the providers. Providers have to observe the relevant professional codes in order to make sure that accurate and updated records on patients are kept. And then concerning the sharing system, there are interface specifications, security, as well as technical specifications, and there will also be test runs or trial runs. And then concerning the use of the EHR sharing system, the information can only be used for healthcare-related purposes, and professional judgment and careful understanding have to be exercised in making use of the information in the system. Now let me talk about system security. So there are security requirements, standards, and policies. For example, use of the PIN and also security maintenance. So these will be updated in the light of technological advancements. All information can be used only in an authorized manner, and unless with the consent of the patient, the information cannot be disclosed to any third party. So healthcare personnel have to, together with the commissioner, act in accordance with the Personal Data Privacy Ordinance and deal with data access requests and data correction requests from patients. So we would now like to hear members' views, and we will be seeking the views of stakeholders on the content of the code. Thank you. All right. Mr. Fernando Zhang, I think we do have sufficient time today, but initially I'll give each member 5 minutes. Yes, thank you, Chairman. Concerning the SDMs, there will be SDMs for those who are mentally incapacitated. So these are the MPR or MIPs. But then, say for someone who is mildly mentally disabled, it's difficult to decide whether he is an MIP. I know of one person who is mildly mentally disabled. He has been diagnosed as mildly mentally disabled, but in fact he can work, he can take care of himself, he can live independently. So is he regarded as an MIP? He does have family members, but then his family members may not make decisions on his behalf in his best interest. Now, I've come across cases where MIPs have deceased parents, but then their siblings have tried to deprive them of their disability allowances. And then let me cite another example for one who is mentally ill. Yes, when he is ill, he may not be able to make informed decisions for himself. But then when he has recovered, then he may have his own very informed views about his own interests. So at what stage does he need an SDM, and at what stage is he not considered to be in need of one? Now, for example, I have a daughter who is severely mentally disabled, and she won't be able to understand the complexities of an EHR sharing system, so she can't make decisions on her behalf. But then, say if I, as his father, applies to be an SDM, that application may not be successful because the application may be successful only in the case of a controversy. So I just want to know whether you're going to amend the mental health ordinance if this bill is passed. Yes, thank you. People join the sharing system on a voluntary basis. Now they can opt to join the system, and then they can opt to place their trust only in certain clinics and certain private hospitals, for example. So the bill allows the patient himself to make his decision whether he is mentally ill or not. So a person or a patient may be a mildly mentally disabled person. And if he comes to our counter and expresses an interest to take part in the system, he can decide to join the system so long as he can produce his ID card or ID document to us. But then for an MIP, there is a possibility that he may not be able to make a decision for himself, or he may have a guardian under the law, and so the parent or the guardian can make a decision on his behalf. And so if the parent or the guardian comes to our counter and tells us that this person, this MIP, wants to join the system, then he can join the system. So the patient can make his decision even if he has a guardian under the ordinance. So I want to say that the patient's personal decision always takes precedence over decisions made by him or made for him by others. And if a person really can't make decisions for himself. Under the bill, there are several groups of people can make decisions for him: parents, guardians, healthcare staff. But of course, the patient can decide which hospitals or clinics to cover in his choice. Now for MIPs, they maybe they do come across cases where certain requests made to the government are rejected, and so there may be a need to review the provisions in another ordinance with regard to guardianship for MIPs. Ms. Lee may wish to elaborate. I want to say that SDMs are different from guardians under another ordinance. Now, if so, SDMs represent an arrangement whereby a person cannot make a decision to join the system, and so an SDM is not equivalent to a guardian under the mental health ordinance. Now, if he is a child, then the guardian may be the parents, and then for an MIP, the guardian may be a parent or a family member, for example, or brother or sister, or even a healthcare provider. So for an SDM, the definition is different from that of a guardian. And concerning the consent to take part in the system, and the person himself or the SDM can make the decision. And so the person himself can make the decision. The SDM arrangement applies only to the EHR sharing system. As to who can help an MIP deal with his other daily affairs, I don't think this can be dealt with in this bill, because this bill merely provides for an SDM arrangement in relation to joining the EHR sharing system. Mr. Cheung, if you wish to follow up, please be concise. Chairman, the difficulty is this. Say someone may be moderately mentally disabled. And he may not understand that there is this EHR sharing system, and that he can join the system. But then say his brother may opt in for him, but then subsequently his sister may think that in fact he's not or he shouldn't really have joined the system. So we will look at the sequence of events. We'll also look at the status of the person giving the consent. Now, Mr. Zhao, if this person himself comes to our office and applies to join the system, then we will accept his application. And then when he chooses the clinics or hospitals, again we will accept his choices. But then if he is accompanied by someone, and he can prove that he is the parent or the guardian or the family member, and then he is the SDM, then at that moment we will register for the person in accordance with the decision of the SDM. But then say 6 months later, another family member, say the sister, comes to our office and tells us that the earlier decision made by the brother is in fact not appropriate. And so if we can prove her identity, say if we can verify that she is the sister of the MIP, then we will accept the application. But then does the SDM have to be accompanied by the MIP. Yes, but then the sister has to be present. The MIP has to be present. But then the brother who made the decision earlier doesn't need to be present. So the patient's choice always comes first. The patient's choice always takes precedence over the decision made for him by others. Say if he wants to opt out, then even if the sister wants him to join the system, he won't be allowed to join the system. And then we can't prove that the sister is closer to him than the brother, and so we look at the status or the identity of the person accompanying the MIP on the latest occasion. Dr. K.K. Kwok, yes, I've got a few questions on the COP, Chairman. Now, the COP is different from the professional code. This I can understand. So this is not a professional code, but then healthcare personnel are expected to observe the professional code. So is it that the professional code should come first? What if in observing the COP, one breaches the professional code? So we have to be very careful about this.
Secondly, explicit and informed consent. How are you going to disseminate this message? Apart from the COP, apart from stating in black and white, will you be organizing seminars and monitoring the situation, in particular for hospitals? Healthcare service providers may not act directly. Other personnel, such as healthcare assistants and other staff members, may also have access to the information. Security requirements, etc. Will there be software or other practical means to ensure that in future healthcare practitioners and healthcare service providers, when using the system, will update the system duly to avoid falling into this trap? And is updating requirement also included in the security requirement? For example, in the professional code, they're not allowed to provide information outside the scope. So be it the nurse, the doctor, or other medical professionals, they should know that on opening an entry, a warning would show up saying that you're trying to access certain information that is within the scope of privacy, and we're still waiting for the Privacy Commissioner's response. And if there are amendments to be proposed by the Bills Committee when it comes to COP and the software, these reminders and possible traps should also be shown in the EHR sharing system. Mr. Chan. Well, I will speak first and then I'll defer to Dr. Wong to supplement. Yes, first of all, on the first point, we agree to Dr. Kwok's suggestion. The COP should not be in conflict with other professional codes of conduct issued by other professional medical organizations, such as the Medical Council. We set out the best practices, the procedures recommended, which may not be duplicating with those in the professional code. But in case of duplication, we should not contradict the professional code. So thank you, Dr. Kwok, for this reminder. We also agree to your second point. When participants give their consent, it must be an informed consent. They must not give consent without knowing anything about the system. This is the same as many other applications in your daily lives, such as credit card applications. The applicant is also required to read through the fine print before giving their consent. And we're going to do publicity work. And as said just now, the participating healthcare service providers will be required to join some training and seminars. This is also along our line of thinking, and that we are going to do, as mentioned. As for updates and how participants will be informed, I'll defer to Dr. Wong. I want to supplement the previous point, how to ensure that the patient's consent is an informed one and an explicit one. We have guidelines for frontline healthcare staff. For example, what message should be sent out to patients so that they understand the system's operation and the scope of information to be shared and the consequences. After understanding the patients, after they are informed, will we get a confirmation from them. Similarly, on the use of Hong Kong ID card, we also require their consent, and we explain to patients in advance what using the ID card means, giving your consent, and we have similar guidelines. As to the other part of the question, whether there are any other ways to ensure that medical practitioners using our system will automatically be able to meet our requirement by, say, for example, installing some software to provide a safer environment. Once the software is used, which is regularly updated, it will make the system better and meeting the security requirement. And some professionals will be given authority to have access to private information, and to what extent. In the course of the design and architecture of the system, we have included the level of authority to be given to the level of healthcare staff. As long as the use of the system is proper, we can ensure that the privacy and security requirements can be met in the future. Chairman, you talked about the insertion of the Hong Kong ID card. This is one of the means, right? If in public hospitals, I can easily understand how it will be used. If it's not a private healthcare service provider, say is a therapist in a clinic or a Chinese medical clinic, then do they have this device? Will the device be provided by the office in the future? Yes, we will provide such for healthcare service providers when they register when they help patients register to give consent. They can rely on this device to indicate their consent. There are tourists, foreigners, and those who do not have Hong Kong ID card, and we also give them another way of showing consent without the use of Hong Kong ID card. Now, this is a card reader, and we understand that for smart ID cards nowadays, a lot of information is stored. We're alarmed because the device can retrieve other information apart from the part that the healthcare professional is required to have access. So how can you ensure that the card reader will never read into such information as well, as part of the system's security? In fact, we have stringent security requirements for healthcare organizations participating in the e-child sharing system. They will use the card reader provided by our office, and the card reader will only be able to read what's written on the ID card, including the name in English, Chinese, and the ID card number. Just the particulars shown on the surface of the ID card. Other information cannot be retrieved by the card reader. What if he doesn't have the ID card? That means the procedure won't be completed. Can it be done manually? Basically, we will provide a card reader to each healthcare service provider under the system. The healthcare service provider may also have to treat patients without Hong Kong ID card, and we do have another set of protocols, and that the show of passport documents or other identity documents may also be done to complete the registration. So when a patient wishes to join and consents to joining the system, the ID card particulars will be required. Yet we also allow the use of other ID information, and that upon our vetting, the patient may also be allowed to register for the system. Dr. Lo Wai Kwok. Now, on the code of practice, there is the mentioning of personal particulars and data privacy. And on this, I'd like to come back to the point about the safe deposit box, and I hope the administration can make it clear. After so much discussion, what is the direction of the administration about safe deposit box? Will this feature be included in the bill as well as in the COP, or will you just undertake that this will be the direction for your work in the next stage? I think if you clarify this point, and if we all agree, we don't have to continue to pursue this point. I personally think that this is a matter of great concern, because with the safe deposit box, the data of a healthcare recipient may be locked by the safe deposit box to the extent that the box withholds too much data and the system will be rendered useless. So I just want to know what actually will be done and what will be your direction. Mr. Chan, on the issue of safe deposit box, I'd like to know whether you have any new thinking or new direction. Dr. Low mentioned the point about safe deposit box, which have been discussed in previous meetings. At the last meeting on the 11th November, we agreed to go along a certain direction. Now we're going to walk members through 4 papers. In the last paper, we'll also give a response to the points raised on the 11th of November. We agree that to some, safe deposit box feature is very useful because some data will be encrypted and access could be prevented. But from the perspective of medical professionals, as we heard in public hearings in the past, if some data is withheld in the safe deposit box, there may be hazards. Both arguments are sound. That's why we are proposing that in this next stage a study will be conducted to see whether we can strike a balance which is acceptable by both parties. A study will be conducted in the first year of stage 2. Well, some members may be concerned that the administration will study whether or not so and so, and in the end, the answer or the outcome will be no, and that it won't be included. So we're undertaking that this study will take a positive direction towards this safe deposit feature in the light of the situation in Hong Kong, to see what data of a patient should be disclosed in order to achieve more. And this is the positive direction we're heading. As for whether the extent of influence by a patient or a doctor, or whether this is just an administrative arrangement or the system will have to be tweaked, we have to conduct the study first. So, as I said, the study will be conducted as soon as possible in the first year of stage 2. But I have to emphasize that this bill is technically neutral. This is not a manual or an operational manual of the system. It doesn't describe or prescribe the use or functions of the system. So, about the safe deposit box function, we do not preclude the future provision of some form of it, and we have yet to do the study. We don't know whether it can only be done through changes to the system, or it can be done administratively. Well, a member last time asked whether we can have a new form of programming to allow a patient a greater extent of influence without preempting how the programming should be done. And last time, it was advised that the legal advisor to the Privacy Commissioner can think about it, and we can also consider it.
But I don't think in this case technical descriptions will be appropriate. The Privacy Commissioner is preparing some amendments to the content of the bill. So we'll wait for those amendments first. And then can you tell us the timetable for your further studies? Yes, Chairman. Now, our blueprint is a 10-year program under 2 phases. So we have already completed all our technical work. When the bill is passed, then we can start the operation of phase 1. And then we can proceed to prepare papers to seek funding from LegCo for phase 2. And we can have the study in the first year of phase 2. So the bill is passed, phase 1 of the system commences operation, and then we'll apply to FC for funding for phase 2. And the study can be carried out in the first year of phase 2. The study won't take 5 years. In other words, we don't need to have to wait till 2019 or 2020 before we can have the new functions. And once we've completed the study, we will try to implement the outcome as soon as possible. Ms. Elizabeth Quat. In fact, we were on the COP, but then as Mr. Loy Kwok has raised the issue of the safe deposit box, I would also like to talk about this feature. I understand that the technical descriptions really can't be written in the bill. But then as the Privacy Commissioner has already agreed to study the matter, we can wait for his reply. But I hope that the administration will not just passively wait for the Privacy Commissioner's recommendations. I hope that you can also proactively do some research, and then we can make a comparison between the Privacy Commissioner's recommendations and the administration's recommendations. So I hope that the administration will not just be passive. And then back to the COP. Now we have the scope of sharing and also the health records that different healthcare personnel can have access to. Now, this I think the content of the COP affects the public greatly. So before you amend the content of the COP, will you first consult the public? In fact, there are lots of COPs, ID card numbers and so on and so forth. And I understand that when they are revised, they have to be gazetted. But then for this one, I think it's not going to be gazetted. I want to know why. Mr. Chen, Chairman, we've always emphasized that this is not a mandatory system or mandatory scheme. It's a voluntary system, and so not all members of the public are going to be affected by the COP. The COP recommends practices to be adopted by healthcare providers. Now, if healthcare providers can think of their own ways which serve the same purpose, then will not disallow those practices. So it is not that healthcare providers must follow this code of practice. This code of practice is not a piece of legislation or a regulatory code. We will be consulting the healthcare providers, the healthcare personnel who will be using this system about their views on the COP. Say, for example, the HCP has to process or complete processing the application within 5 days from the receipt of the application. Now, we may think this is feasible, but then healthcare providers may think that they need 9 to 10 days, so they are welcome to give their views. In future, if we propose major changes to the content of the COP, and if these changes may result in the change of the modus operandi of the HCPs, and of course we'll have to consult them, because there is no use amending the content when HCPs aren't or won't be able to comply. As to whether or why this code can't be gazetted, we can consider gazetting it, but then the COP is not subsidiary legislation. Now, yes, we can publish it in the Gazette for public information, but that doesn't mean that the COP will become subsidiary legislation. Dr. Wong or Ms. Lee? Yes, Chairman, with regard to Ms. Scott's question, in particular, why we didn't carry out a public consultation exercise when we drafted the COP. I want to say that we have briefed 13 medical boards and councils on the content of the COP. The Hospital Authority, the Department of Health, and the health or the CHP have been made aware of the content of the COP, and our in fact committees comprise patient groups and also representatives from the OGO, and they are fully aware of the content of the COP and its scope. Meanwhile, the Privacy Commissioner has been given a copy of the draft, and in fact we've also got a consultancy study on the privacy impact assessment. So when, in fact, we have effectively sought the views of the relevant parties in a focused manner. And we don't think the content of the COP is very controversial. The COP is about best practices and in fact, in the professional codes of conduct observed by doctors and other healthcare personnel, and also in the codes on the use of software, I think the content is similar. And so I think a more flexible way to update the content of the code will be more appropriate. Ms. Kwat, I don't really fully understand, and I think some of the views I've heard are conflicting. We are told that participating in the system is voluntary, and so the code it's not a mandatory one. But then, as they have joined the system, they have to observe the code. I think the code, like many other similar codes, is supposed to be binding. And then we've heard that consultation has been carried out, briefings have been given to relevant organizations. And so I want to know why you can't carry out public consultation and why you can't gazette the COP. I think gazetto of the COP will give it the proper status, and also I think gazetting the COP is a way to formally make the COP known to the public. So why can't you make use of the gazetto procedure or process to formally tell the public that there is this COP? I think Ms. Kwat has a point. Now, in fact, the Privacy Commissioner has published guidelines on the use of the ID card number and also the use of mobile apps, and I believe those haven't been gazetted. So can the DOJ tell us the difference between the COP and other codes or guidelines? It seems that this COP is vital and instrumental for the implementation of this system, and so won't it be more appropriate to make the COP subsidiary legislation? I just want to know under what circumstances a COP is made subsidiary legislation. Now I want to say that Section 12 of the Personal Data Privacy Ordinance is about the making of guidelines and codes, and I would like to know why this code or this COP under the bill is not subsidiary legislation. Yes, Ms. Chai. Thank you, Chairman. I would like to refer to clause 51(2) of the bill. It says that the Commissioner may issue a code or must publish the code in a manner appropriate to bringing it to the notice of persons affected by it, and must make copies of the code of practice available to the public in hard copy or electronic form. So it doesn't really rule out the possibility of gazetto. It just says that he must publish the code in a manner appropriate to bringing it to the notice of persons affected by it. So the code may not be subsidiary legislation, yet it can still be gazetted, right? So can you perhaps explain to us the difference? Now, the fact that a code is gazetted doesn't mean that it is or is not subsidiary legislation. You have to look at the nature of the code to see whether it is subsidiary legislation or not. It is not that only subsidiary legislation can be gazetted. So under what circumstances we will decide to gazette a code, and under what circumstances we decide against that? Now, Ms. Quat, gazetto is one action. Whether the content is subsidiary legislation is another matter. Now, subsidiary legislation is, of course, needs to be gazetted, but it doesn't mean that all gazette notices are subsidiary legislation. In fact, gazetto is just one additional way for the administration to tell the public that there is this code or there is this document. Now, in fact, Clause 51(2) stipulates that the Commissioner must publish the code in a manner appropriate to bringing it to the notice of persons affected by it, and must make copies of the code of practice available to the public in hard copy or electronic form. So the Commissioner can't simply publish the code without informing the public. And concerning how we can make the code known to the public, we can make use of our electronic newsletters or our notices, or we may even gazette the code.
But we want to emphasize that this is not subsidiary legislation. As we understand at present, similar codes of practice in Hong Kong are not subsidiary legislation, even if they're gazetted. The reason is that these COPs or professional codes of conduct, etc., they contain they are rather technical in the systems where they're used. For example, on the use of gas heaters or the facilities or machinery in the public pleasure grounds, how they should be used. They're very technical, and the details may be set out by the EMSD, whereas for professional bodies, such as for doctors, nurses, architects, etc., usually they have a professional body to regulate the sector. They're regulated by their professional bodies, not by the legislation as such. So, on how we should use the COP, we believe that the nature is not one of subsidiary legislation. But if Dr. Quat thinks that it's not safe enough to let the practitioners print out the COP and have it put up outside the clinics, then we can consider gazetting the COP. Yes, please do. And for non-compliant healthcare service providers, what will happen to them? Will they be breaching the law? Well, let's say if you decide that in 7 days they should do so and so, and if they don't comply, then what will happen? Well, the COP touches upon different areas. Some may be administrative, some may be security related. Well, as I said just now, even if they don't follow the COP, they may not have operational difficulties. For example, we may suggest that 3 locks be used to lock up a machine, but they may have better ways. For example, to use 5 locks. But if what if they don't even use 1 lock? If not a single lock is used, and if there is a loss of data, then we decide whether the consequence of that will constitute any criminal offense or offenses set out in the bill, and for which they will be penalized. Well, in the future, the commissioner has the power to suspend or revoke the registration of the healthcare service provider if they are in breach of certain provisions or the rules in the COP. But as I said just now, a mere breach of the COP may not attract penalty, because as long as the operation is still the same by using their own ways, then they'll be fine. First round, Dr. Leung Ka-Lau. I'd like to follow up on para 7 of the administration's response. Now, after a patient gives consent, then the healthcare service provider can upload all the data onto the e-child sharing system. So para 7 confirms that there is no way the patient can follow up on this matter. That is, it's up to the HCP to decide whether to exclude the data to be uploaded on the system. If for some reason, even if the HCR has made such a request, the data is still uploaded, then there is no way for the HCR to pursue the matter. Well, in fact, Dr. Lau is referring to CB Bracket 2404 para 7 about points raised at the last meeting. Well, if a patient requests that a doctor refrain from putting a certain portion of the data online for sharing, then is it possible? And we explain in para 7 that in stage 1 design of the HR sharing system, and depending on the local electronic medical record systems of the healthcare service providers, a patient may ask a doctor not to upload a part of the patient's data for sharing on the system. And if the system does allow the withholding of such particular data, and it will be subject to the HCP's professional clinical judgment, then it can be done. However, for the electronic medical record systems of some clinics, after installing the software provided by us, maybe all 9 modules have been installed. Then once the data is entered, then there's no way to stop it. The only way to stop it is not to input the data into the system. This is what we try to explain in para 7. Ultimately, whether the doctor accepts the patient's request not to input the data into the system, then that will depend on the professional and clinical judgment of the doctor, and whether by doing so it will be a breach of the professional code. That is, a clinical record of the patient should be kept. Well, you always say that the bill is technically neutral or is technology neutral. Why is it that this is subject to the constraints of the design of the system? In clause 12.6, what we say is that after a patient gives consent to the healthcare service provider for sharing the data in the system, then this healthcare service provider or the hospital may share the data in all 9 modules of the system. This is the purpose of clause 12.6. Well, you say that this is technology neutral. Here it doesn't say data in all 9 modules. So it's more than the data in the 9 modules as far as this clause is concerned. You say that for the 9 types of data, they will be uploaded, but in fact at any time the data can be uploaded. First of all, only the 9 types of data under the shareable, within the shareable scope can be uploaded. That means it's a maximum of 9. And secondly, as I've explained just now, some clinics may not have installed all the modules required for uploading these 9 types of data. Maybe only 4 or 5 modules are installed. So in that case, only 4 or 5 types of data can be shared, not all. So the extent of sharing may be different, but the maximum number is 9. For data outside the 9 types, then they are not eligible for uploading, and it will be a breach of the law. Well, but in your bill, it says nothing about the 9 types of data. So without amending the ordinance in future, you can just make changes to the COP. So you say the bill is technology neutral, but here, after giving consent to use the sharing system, even if before that the patient is told the doctor not to share certain data, if the data is ultimately shared, then the patient doesn't have any way to pursue the matter. That is my question. Well, yes, the doctor may not have given the undertaking, but previously, since the patient has given consent, then for some reason the data is uploaded. Perhaps the doctor is working for a group, and for some reasons the doctor may have to keep some data or have it printed out in hard copy, and then for some reason the data is now in the system. Now, my question just now was, there is no way for the patient to pursue the matter. Now, what if the doctor has agreed, then the patient may not be able to pursue under clause 12.6, but he can complain to the medical council. Let's say if the doctor is just an employee, he has to prepare an electronic record, and then the medical or the healthcare group in one go just uploads all the data. Then the doctor is in no control of the data which is uploaded. So under this bill, there is no way for the patient to pursue the matter. Under the bill, the patient cannot pursue the matter because previously the patient has given consent to this hospital participating in this system to upload the 9 types of data in the system. I have repeatedly told you that the doctor is not in control of the system. Don't use the term doctor, because the healthcare service provider, under the design of your bill, is that it is the HCP, the healthcare service provider, which makes the application, not individual doctors. Let's say for psychiatric patients' records in the HA, even if there is CMS, the record stays within the CMS. It won't be uploaded online, right? The CMS this data is confined to within the CMS. It cannot be shared outside unless, say, authority is given or consent is given to private practitioners joining the sharing system. However, in future, for sensitive data, once the patient agrees to join the system, consent is automatically given to HA, and all the data can be uploaded onto the system, and then any third-party participants, those healthcare service providers, can have full access. So once the bill is passed, the patients will be given less protection than what they currently enjoy. I think there is some misunderstanding, so allow me to supplement. First of all, for stage 1 of the HRSS, as pointed out by Mr. Chen just now, for clause 12.6 is an enabling provision. That is, if the patient has given consent, the HCP can share the shareable data. That allows the HCP to do so. Dr. Leung talked about sensitive data and asked whether the HCP can upload all the shareable data, including sensitive data. Well, in fact, the consent only covers shareable data. In CB 2/221/1415(02), it sets out the scope of shareable data, which includes personal ID, adverse reactions and allergies, and diagnosis, so on, etc. As for sensitive data and clinical notes, and maybe the HA colleagues can confirm, it's not part of the shareable scope. The consent for sharing only covers shareable data of which the patient has given consent to upload onto the system. So the protection will not be lessened, because it doesn't mean that all the clinical notes or all the data in the computer will have to be uploaded. And it's also a voluntary sharing consent, so it's optional whether to give the consent or not, and the consent can be revoked.
So in fact, the recipient has or can make the decision, ultimate decision. Can I still be given some time to follow up, Chairman? Okay. So you are assuming that all shareable data are non-sensitive data. So you're in fact, a lot of the shareable data are in fact also sensitive data. If I remember correctly, there will be summaries, and the summaries may contain sensitive data or information. And then concerning laboratory tests, for example, ACE test results, these can be very sensitive. And I really don't know what to say. You said that the sharing consent could be withdrawn. But then what had been uploaded could not be deleted. That's what is written in down in the bill. Is that right? So if I withdraw my consent, say if a patient withdraws his consent to join the system, what was uploaded because of his previous consent will not be removed from the system because of his subsequent withdrawal. Am I correct? All right, so if someone withdraws from the system, will all the data be deleted? And the second question is it that shareable data also contain sensitive data? I did not say that shareable data did not contain sensitive data. I was merely trying to say that concerning data on mental illnesses, they were not within the scope of sharing. And then if a patient withdraws his consent to share the information, then the healthcare providers can no longer upload his new data, and these providers can no longer access his data. So if a patient withdraws his consent, then for data kept in the system, healthcare providers cannot have access to such data, but the data will not be removed or deleted. We have to follow the requirements of the Personal Data Privacy Ordinance, Chairman. Concerning the use of the data by data users and the retention, there are certain requirements in the ordinance. And if such data are no longer required, then there is a responsibility to remove the data. And so we will have data removal policies which will apply when patients withdraw their consent. So because you gave us the impression that the data would not be removed, but HCPs would not have access to the data. But now you seem to suggest that the data will be removed. There will be policies to remove the data, but then it doesn't mean that everything will be removed or deleted, because the patients may need to have access to some of the data. So in other words, you may say remove the data only after a certain period of time. And then concerning shareable data versus sensitive data, anyone who would like to reply to Dr. Leung's question? Dr. Wong. Yes, Chairman. Shareable data may consist of confidential or sensitive data. But then we hope that even if the patient has given consent and there is subsequent sharing of the data, there will still be a need for medical personnel to comply with or observe the confidentiality requirement. This requirement will not be diminished in any way. Now, just imagine what's going to happen in phase 2. Maybe patients will be given more choices. For example, certain data will not be uploaded onto the system. But if the patient has indicated that he doesn't want certain data to be uploaded, then under normal circumstances, that data will not be uploaded. But then, because of some interfacing arrangements, the data are ultimately uploaded. And does it mean that the patient can't take any action? Now, we emphasize the need to have the patient's consent, and after all, medical personnel have to observe the rule of confidentiality. In other words, the information will not be disclosed to another third party without the consent of the patient. Dr. Leung wants to know who will be held responsible, the doctor or the hospital, because Dr. Leung said many times that the doctor was merely an employee. He had to upload the data. In my view, the institution has to bear the responsibility, because the consent is given to the HA, to the Department of Health, or to a private hospital to access the records, and the doctor can access the records because he is an employee of the HA, the DOH, or a particular private hospital. All right, I think we will have to move on. We can come back to this one later if we have time. Dr. Fernando Zhang. Of course, it's good to have the EHR sharing system. The system should be beneficial to patients. But then in the case of the need of an SDM, I think the arrangements are not entirely satisfactory. So the person may be regarded as someone who can't make a decision for himself, and then the brother makes a decision for him, and then subsequently the sister comes along and makes another decision for him, and you just look at this the sequence of the decision and so long as you can establish a relationship between the SDM and the MIP, then you follow the decision or the choice made on the latest location. And there are some MIPs who cannot physically go to your office, and so you totally rely on the carers to make decisions for them. I think you really have to find a way out to this situation. I think the proposed arrangements are unsatisfactory. And will you have staff explaining the arrangements to the SDMs and the MIPs. Chairman, during the public consultation exercise, situations mentioned by Mr. Zhang were raised. People do think it's a good idea to have SDMs, and the order of priority is parents, guardians, family members, and then healthcare personnel. Right, so parents, guardians, family members, and if this MIP doesn't have any family members, then the doctor or the healthcare personnel. But then when we come to family members, the situation can be difficult. Who should come first, the elder brother, the elder sister, or the younger brother? Because another person may come and override a choice or a decision made by another family member. So this is a difficult situation. Now say a person may need to undergo an operation, and it's not really a matter of life and death, and he has some siblings, and then the siblings may have different views as to whether this person, whether this MIP should undergo the operation. Yes, we understand that the proposed arrangements are not entirely satisfactory, but then we can't really decide on an order of priority among family members. So what we can say is that the patient's choice always comes first, and next the parents and the guardians, and then family members. I think we can really only go that far. Parents and then family members. What about the spouse? Parents and then guardians. Mr. Zhang, any suggestions? Now, the administration has admitted that the proposed arrangements are not entirely satisfactory. But then, do you have any suggestions? I wonder if the administration can really come up with better suggestions. Under the present guardianship regime, when there is a controversy, then a family member can apply to be the guardian. But obviously, the functions and roles of guardians do not include the function of an SDM, for obvious reasons. And so perhaps you will have to talk to the Labor and Welfare Bureau about the expanded roles of guardians. And yes, there are some MIPs who do not have family members, or their family members have all left Hong Kong, and these MIPs are in the residential homes, and the SWD is not their agents. And in fact, some of these elderly persons have in fact deposited their savings passbooks with the elderly homes, and these elderly persons may not know that there is this e-sharing system, but then this e-sharing system definitely can benefit them. So how can you make sure that they will also know of such a system?
So, like we said just now, if there are parents, if there are guardians, then they can help the patient. But if the patient doesn't have any one of those, and if the patient stays in the home, then we look at the bill. Healthcare service providers don't just include hospitals, clinics. It includes residential care homes as well, as long as there are medical professionals resident in the home, and they will be qualified to act on the patient's behalf. And as we said just now, we have launched a publicity campaign. We explain to care homes and the residents therein that the benefits of this system, and if they don't have any family member, then the home may act on its behalf. And we're also going to have hotline, and our staff members will answer their questions should they phone in. Well, Chairman, I'm concerned about this. For subvented homes, and I'm not too worried about them. For private homes, however, they may wish to save the trouble. They may wish to opt out and not allow elderly residents to join the system in order to save the trouble. They may feel cumbersome if all the data is shared. And there are residents who cannot receive information outside. They may not know anything about the EHRSS. Well, in that case, we can do nothing but to step up our publicity, because, say, for a private home, for some reason, which knows about this good system and yet doesn't apply on behalf of the elderly residents, well, because it's on a voluntary basis. Well, I think Dr. Zhang may be referring to some possible conflict of interest. And if there is another way to deal with it, say under the guardianship legislation, or another welfare unit can take over the matter. And he's asking whether this can possibly resolve the problem. So the first point is whether the administration would ask the Labour and Welfare Bureau and see if it's possible to assist and to seek their views. This may be a solution. Also, Dr. Wong would like to implement supplement, right? Yes, responding to Dr. Fernando Cheung's question. Now, in principle, to give a consent for a person for an MIP to join the sharing system, the consent should be given for the benefit of the patient, and family members and others may be SEMs, and there could be disputes. However, when it comes to decisions, we're not talking about what medicine to be prescribed, whether to undergo a surgery in relation to the patient. It's about sharing of data. For the SCMs who may make decisions on behalf of the patient, they do not benefit from it. The decision. Well, of course, we cannot rule out the possibility of the SDMs arguing among themselves, but the risk is quite low. And when it is decided that the patient should join the system, the SDM will not have a copy of the records. The SDM only consents to the record being kept by others. The health records would only be accessed by those who have the authority to do so under the PDPO. And Dr. Fernando Cheung's concern may be about this. The existing legislation to follow is PDPO, and the system has a particular list of persons who are specified persons for retrieving the records. As for MIPs, under the existing legislation, if no guardianship can be arranged for the MIP, it may be more difficult for the MIP to retrieve his own medical record. So that would depend on whether the approval of guardianship for these MIPs may be given as much as possible by the relevant authority. Well, in the private care homes, some elderly residents do not have family members at all, and they don't know anything about the system. After joining the EHRSS, the private home may become one of the liable organizations, and they may wish to opt out in order to save trouble. Well, a brief response from our years of experience. In fact, for elderly residents in care homes, well, the homes do provide as much as possible, or do keep as much as possible, the records of these elderly patients. I mean, even for the hospitals, they do keep a record, and because it's troublesome to ring the homes to check the dietary records or the prescriptions of patients. It may not be in the best interests of patients if the homes do not join the system. And therefore, we'll do more publicity, and we'll try to work with the homes such that it won't be too cumbersome for the homes to join the EHRSS so that all patients can benefit. We have Dr. Leung Ka-lau and Dr. Elizabeth Quat. The meeting will be adjourned at 12:45. Now, I won't follow up on the last point. Now, I'd like to refer to another point on the 11th of November. In fact, we have 4 papers. We'll try to go through them one by one, and we're still on the first paper. And you're talking about the 4th. Shall we wait for the next time? Because originally we were supposed to ask the administration to go through the papers one by one. I want to know if your question is urgent or not. All right, not urgent. Perhaps I will wait for next time. I want to make one comment following Dr. Fernando Zhang's question on SDMs. I raised this point before as in existing medical practices. For those without family members, or for those having family members who have different views, and if those patients are unable to make decisions themselves, according to the existing legislation, it is the medical professional who can make decision on these patients' behalf. They're given priority because in the legislation it's hard to actually prioritize different family members, whether the spouse should go first, or children, or parents. The list will be endless. Now the existing legislation is this. The doctor giving medical treatment to the patient can make such a decision. Of course, when making this decision, the doctor is required to follow the professional code to make sure that he's acting for the best interest of the patient, which is exactly the opposite of the priority of SDMs in your bill. So about this all along, I have suggested that you should reconsider whether this is in line with the existing practice. In fact, before Dr. Leung arrived, in the beginning of this meeting, we discussed this issue. In terms of medical treatment, the medical doctor's decision should be given top priority. But as far as this SDM arrangement is concerned, it's about whether to join the sharing system. It's not a life and death situation. So applying to join the scheme, or which HCP to authorize. On these matters, we allow parents and family members to be given a higher priority than medical doctors. For medical treatment, well, even the bill is passed, the medical doctor will still be given priority. But you mentioned that the family member yes, if the patient is unable to make a decision, and if he doesn't have any family members, no parents, etc., then the medical doctor, or maybe HCP, or the care homes who assisted the patient in joining the scheme may make the decision. The problem is sometimes the patient may have family members, but the family members may decide not to allow him to join. So what happens? So the question is whether the family members can decide whether to join or not. Say, as mentioned by Dr. Leung, there may be parents of a patient who disallow the patient to join. In the latter case, ultimately the doctor it may be more convenient for the doctor to decide whether to join or not. In the other case, however, you don't know whether the family members will opt in or not. So it's a different scenario from refusing to join. Now, if the patient comes forward for registration, then we register for the patient. If the patient is accompanied by the guardian or the parents, and as they are eligible SDMs, we will also register for them. And what if the patient is living in the RCG and he is accompanied by a staff member of the RCG, and if the RCG is an eligible HCP, then the RCG can register on their behalf. As I said just now, if our staff finds somebody coming along by himself and he now decides not to join, then the wish of the patient is always given top priority. We respect the wish, and that's why I say that the doctors don't always have priority. Let me give you a more clearer example. Let's say if the patient is unable to make decisions, and then a family member comes forward and says that he can make decision on behalf of the patient, and he decides to join, and then another family member comes and refuses to join, then does it mean that the doctor can now make a decision? Parents go first, followed by family members. As for which sibling should go first, well, it's a matter of logic. The SDM sometimes you may not be able to set priority for each and every of them. Say if there are two SDMs of the same priority, and one says yes, the other says no, then according to your bill, as long as one says yes, then the patient can join, or will you also have to consider the person saying no? Well, if somebody comes along with his sister, and his sister supports participation, then the patient joins the scheme. If the following day the brother says no, then the patient withdraws from the scheme. And you're asking about the sister and the brother coming along at the same time with different views, what should happen? Then it's up to them, the two of them, to make a decision first. Apart from the setting of priorities, they're saying that this possibility is quite low, because it is not the same as for performing surgeries or medical prescriptions or not. It's just about whether the data should be shared in the system, and they don't expect much controversies.
Chairman, it's difficult to put the doctor before the parents or the siblings. So, is it that for important decisions, doctors should come first? But of course, doctors can really sort of underwrite. So you mean if he has no family members? I want to say that there is no mechanism for a family member to come forward and say he can't make a decision himself. I am his younger brother, or I am his parent, and so if anyone comes to you and tells you that he should join the system, I stand to object. So you don't have such a system, right, or mechanism? But of course, with regard to this so-called loophole, we do not know whether such a situation is very likely to arise. And if so someone wants to withdraw and he has withdrawn, then does or is that evidence that he in fact is not joining, he will not join, or so I think we have had a very detailed discussion on this matter. I just want to say that concerning giving sharing consent for a certain HCP. Now, I want to say that if it is an emergency situation, that under the present system there is already emergency access. Say if a patient is in coma, and the doctor needs to know his data kept in the system. In fact, this is already allowed under the Personal Data Privacy Ordinance. And emergency access is allowed. But of course, emergency access can't be used lightly, and there are certain conditions to satisfy. And we're not putting doctors at the top of the list of SDMs, and also it's not for a doctor to decide whether the elder brother or the elder sister should make a decision for the younger brother. And we understand that some private homes for the elderly, their operators are concerned about their responsibilities. And now an SMS message will be sent to the patient or the SDM if his data has been or have been studied. We understand that operators of private homes for the elderly are now handling daily affairs on behalf of elderly persons, and so maybe these operators may in future become the SDMs and may receive the SMS messages on behalf of the elderly persons. So it's unlikely that the doctor will be the SDM, and also it's not for the doctor to sort out family ties and relationships for the patients, right? Just a simple point, Chairman. In fact, taking part or joining the system is in itself a medical decision. Do you agree? Joining the system, giving sharing consent, these are in fact medical decisions. And so if you need to get SDMs to make medical decisions, I think the approach should be consistent with the approach in other medical cases. I'm not telling you who is closer to the patient. I just want you to follow the arrangements in other ordinances in the event that medical decisions need to be made. So doctors should come first, because doctors have to work in the best interest of patients, or else they will have to bear certain consequences. But if doctors can come first, then it's no longer a voluntary system. But then doctors at some stage need to make a decision. But of course, doctors, as far as possible, approach the family members for a decision. Now say you think I am an MIP, you are my doctor, you make a decision on my behalf, and then my parents rule your decision. Not chairman. If you can't make a decision, sometimes there's an emergency, I need to perform an operation on you. But then you really might as well take out healthcare providers from the list of SDMs, because I'm just worried that there are inconsistent practices for exercising medical decisions. Now, please do not make the scope of medical decisions too wide. As far as treatment is concerned, the doctor's decisions always come first. But then here we're talking about a decision to join the system or not, and to choose the hospitals or clinics concerned. So making a decision now or a month later doesn't really make a lot of difference. It's not a matter of life and death. If he can't make a decision, let his family members decide. If he has no family members, then the home for the elderly can make a decision for him. And then you may think this is a medical decision, and so the doctor should make the decision because doctors are duty bound to work for the best interests of the patients. But then I'm not challenging this point. But then concerning the elderly flu vaccination program, the healthcare vouchers for the elderly, it's for the elderly to decide whether to join. But then these are people who can make their own decisions. But then here, yes, we're talking about who can make decisions for those MIPs. Now, I have already said what I want to say. It's really not meaningful to go on arguing. Now Ms. Quad is queuing up to ask questions. We have about 5 minutes left, and I hope that I can ask a follow-up question. Concerning the COP, what if someone breaches the COP? What if someone doesn't follow the COP? I want to know whether you can issue a notice of improvement or remedy to the HCP concerned, instead of merely disqualifying the HCP from joining the system. Chairman, the Commissioner can issue guidelines to HCPs on improvement measures, but they are not orders. Orders, these are recommendations for improvements. Guidelines for improvements. Will also warn that if the guidelines are not followed, then the healthcare provider concerned may be disqualified. But then will you also put this down in the COP? Will you put this arrangement down in the COP? You mean if someone breaches the COP, or if a healthcare provider breaches the COP, will you in the COP state the possibility that if the COP is not followed, then the HCP may be disqualified? Yes, we can include that. So we were told that briefings had been given to relevant organizations and bodies on the COP. Is there a briefing paper? We don't have a paper. We just went to the medical boards and councils to tell them what we had been doing. If there is a briefing paper, on the content of the COP, then we'd like to have a copy of it. Now, because we haven't finished drafting the COP, and so in fact we just used the PowerPoints you just saw to consult the medical bodies. Very often the COPs are not ready even when the legislation is enacted. So when will the COP be ready, or when will the first draft be ready at least? Or will you be able to finalize the COP only after you are certain of the content of the legislation? Will you be able to finalize the COP before the passage of the bill? The COP helps people to make use of the system and to avoid breaking the law. And the COP also contains security measures, so the COP will be ready only after the bill has been passed. But then the COP will be ready before the system starts operation. I think time's up. We have only got 2 minutes left. So concerning the COP and its first draft, I believe members are interested. And so please let us have the draft when it is ready. Now we've only discussed one out of the 4 papers. In fact, there are 5. The second and third papers address the Privacy Commissioner's concerns. So I think next time we can go to the 4th paper. In other words, our response to issues raised on the 14th of October 2014. Alright, if there is no objection, then we can deal with the 4th paper next time. So next time we will go to the 4th paper. I will assume that we've already covered the first paper, and we will deal with the 4th paper next time. Alright, so the meeting is adjourned, and the next meeting will be held, I believe, in early January. Thank you.